Anyview ये हमारे कॉन्फ्रेंस रूम है, तो उसका एक व्यू। ये हमारे ट्रेनर है। ठीक है, अस्सलाम वालेकुम फ्रेंड, गुड मॉर्निंग। आज हमें बायोलाइट पेशेंट मोनिटर्स का ट्रेनिंग है और ये कॉन्फ्रेंस रूम में देख सकते हैं। तो ये हमारे चाइना से आए हैं ट्रेनर। तो इंशाअल्लाह आज इसका ट्रेनिंग देखेंगे कैसा रहता है।
My name is Dr. Sakib. I'm from Pakistan and I am at the BioLife headquarters in Zhuhai. Okay? So this patient monitor that you're seeing over here is by BioLife, and I hope you guys have used it before. So how many have you used this monitor? If you have, can you raise your hand? Yeah, okay. Everyone has used it. So how many of you like it? Raise your hand. Okay. So I'm here to collect any of your feedbacks, and if you have any problems with using it, okay? Because at the headquarters, if you have, I'm the doctor, so if there is any problem with it or any usability issues, I'm the one who will tell, and we will go back and resolve them, okay? So if you have any software bugs or whenever you're using it, there is some just some error that you don't want to see there, or there are too many alarms or stuff like that, or anything that annoys you, okay? You can tell me, and I have a small feedback form over here that I will need you to sign at the end. I know it's a long feedback form, so I'm not going to ask you to fill it, but you can just tell me what your problems are and I will write them down, okay? And we will help you to resolve them. Okay, so I want to know which departments you are from first. So can we start from over here?
I'm Maylani from EMS.
From which?
AR, sir.
Yeah. Thank you. How about you? Endoscopy, okay? Endoscopy, all right? Labor room, okay? Medical ward. Surgical ward. Okay. Good. All right. So we have people from everywhere here. Okay. Well, because I see that the parameters we have here might not be the ones you are maybe, because in the PowerPoint we have all the parameters that I will show you, and maybe some of them will be applicable to you, some of them will not be applicable to you. But I will go through them because I hope I made an interesting PowerPoint. So even if it's not applicable to you, maybe it's fun to learn, right? Okay. And I hope sometimes maybe you go to different departments, different areas, so you will know, oh, I know what he's using, I know exactly what they're doing. Okay. So, anyways, before I go into the PowerPoint, I just want to ask you some things directly from the monitor itself, okay? So, this is a touchscreen monitor, as we know, right? So, who can tell me, okay, it's not a test, but who can tell me how to adjust the volume? Can someone tell me how to adjust the volume, like make it louder or make it quieter?
Yeah, click on the corner speakers.
Just
Touch the speaker logo in the corner.
Okay, you want to show us? Come over here.
There is a monitor on. Confused.
So just touch this one.
Yeah,
Then you can adjust volume.
yeah. Plus and minus.
That's nice, right?
With the logo.
Okay, thank you very much. So, do you think it's easy to adjust the volume like this? Yeah. It's fairly easy, it's not very hard. But we have a better way actually. Who knows another way?
to the user.
Yeah?
Set
Okay.
up menu.
Okay, I will show you something maybe you haven't seen before, okay? So let's go over here. Maybe you guys have Android phones or iPhones, and sometimes you have gesture controls. We also have gesture controls over here. So if you want to adjust the volume, all you need to do is like go down with 2 fingers,
Oh,
and you can adjust the volume. So this is on the right side of the screen, okay? This is a capacitive touch screen, just like on your phone. So it's able to, you're able to do multi-finger gestures on here. So for example, so you see I have decreased the volume to 2. You guys are a bit far. If you want to come closer, please.
So we don't know this one.
Okay, now you know.
Now we know.
Now you know.
that's-
So this is the purpose of this training, to show you some tricks. Maybe they will make your life better. Okay. Now you're in the ward, you're dealing with your patient. It's already quite annoying. I don't want to deal with another button to press and again and go into the menus. Which button it is annoying, right? Just do this. Okay, there you go. Maximum volume. Okay. Oh, I hate alarms. Okay. Minimum volume. You can go over here and set that. Okay. Now I have another question. How do you adjust the brightness?
same like left side maybe.
Yeah, you're right. Can you show us? Okay, you're recording. Okay, I'll do it. So if you come on the left side of the monitor, so you can think of it as half of the screen is for volume control and the half screen is for brightness control. So if I go over here, you can very easily control the brightness. So it's nighttime, right? The kid wants to sleep. Okay, just make it down. Okay, and then you just go over here.
Similar like a Android screen. Yeah.
Yeah.
It's similar like a Android
This is a
screen.
night mode, that one.
Yes.
And also on the night mode.
Yes. Actually, even your Android cannot do that.
Yeah, it's exactly
Yeah.
the same.
In your Android, you have to pull down the tab and you have to slide it, right? Even your Android cannot do what our monitor do. Our monitor is more advanced than Android. Agree?
Yes.
Okay. So,
You know.
like that, there we go. Actually, this system, the monitor system, is Android based. It's not Android exactly, it's Linux, but it is kind of similar, right?
It's Linux.
Yeah, Linux. Alright, so here's the volume, that's the minimum, that's the minimum. Okay, now, do you know this screen that we're using currently is called the normal screen, right? The standard screen, where we have all the parameters on the main area here, and here we have, so these are the waveforms, and here we have all the parameters. Now, what can I do if I want to change a screen? If I want to go to another screen, let's say I want to go to dynamic trend screen, where there are lots of trends, not just parameters. Who knows how to do that? No? Okay. So there are 2 ways. There is the hard way and then, not very hard way, but yeah, the harder way. And then there's the easy way. So let's go the harder way first, okay?
Wheel.
So here we have a menu, a main menu. It's always over there, okay? So we can go over here. And you see there are a couple of columns over here. So I can go over here and choose display. Okay, so here you can see there is display. It's a menu. And in this display, the first one is called screen select. So I can go over here, and here I can choose the screen I want. So for example, I want the dynamic trend screen. I'm going to click this one, close that, and we are in dynamic trend screen. So I think this is how you would normally change the screen if you want to. But first, I have a question. What is the purpose of the dynamic trend screen? Why do we have this? Why do we have different screens on here? Does anybody know?
Even me, I don't know.
You don't know. Okay. So,
Dynamic.
so the trend screen is what it's doing. Is dynamic trend. You see here we have trends. You see. So here not only okay. Imagine this. This is just the normal standard screen over here, and now you also have some other things over here, which is the dynamic trend. Okay. And if you look over here, it's showing you the last 30 minutes of trends. I can click over here and I can change that trend length to 8 hours if I want, okay? Or 1 hour, 8, whatever, okay? So you change it to 8 hours, and now I would be looking at an 8-hour trend. So for example, I want to monitor a patient's blood pressure through over, let's say in the morning, okay? Over a period of 8 hours. So we can set the sequence, the NIVP sequence, if you guys know that. So I can go over NIVP measure, and I want the NIVP to be measured every hour, okay? So I can just click the 1 hour one. Where is it? 30 minutes? No, 1 hour, okay? So I click this one. So every hour, we will automatically get a NIVP reading, right? Now, for 8 hours, I should be able to see that over the trend data over here, okay? So this is the kind of use case. Okay, now let's say I just want to go back because maybe the screen area has been reduced for the waveforms. I just want to go back to the normal screen. What should I do?
Yeah.
Well, I can go to the main menu and do that, but there's another way. Who can guess? Here you go. So we use 2 fingers to swipe, okay? And so this is the remote view screen, and we just keep swiping until we get to the So we are in the normal screen, okay? And, okay, so
Hello?
you can see that this normal screen
Yes, sir.
has a couple of parameters. So what if I want to change the order of them? Maybe I don't like, I don't like the respiratory being, the respiratory parameter below the ECG. I want it to be below SpO2. Do you know how to change that? So again, you can go in here, you can go into the main menu, you can click on Screen Layout, okay? So there's a button called Screen Layout. And here, you can see that there is a screen layout, and you see here respiratory, I can change it to, let's say, SpO2, and the third one, I change it to, SpO2, and I change this to respiratory. When I close, you can see the position has been switched. It's that easy, and I can also change the colors in there. So if I show you how to change the color, that's based on your liking. So I just click on, click on parameter color. So let's say I want to change the SpO2 to maybe blue. There we go. Now it's blue. So you can change them to whatever you like. Now, why is this important? It's because maybe you worked at some other place using some other device, some other monitor, and you were used to those colors in those areas. Maybe the pulse rate was always green, or the SpO2 was dark blue or light blue or whatever. So you can go in here and tweak the colors according to your liking. Another thing is, we have done some research and we realized that no matter how big we write the words over here, they're always too small for someone to read them from a distance. So right now you're sitting at some distance, it's very hard for you to read which parameter it is, right? But what you can do is you can see the color. So if you have a color code in your department, so for example, okay, in our department, all SpO2 is red, okay? So no matter where you are in the room, even over there, you can see the red one is SpO2, and you should be able to tell the value, okay? From even far away, okay? So here are some things. So anyone wants to come here and try? Okay. Who wants to come in here and try some of the things we just talked about? Anybody?
User.
Okay.
The user should be.
Alright, come on.
Anyone can just go there.
No, experiment should be the user.
User should be go there.
Okay. So could you change the brightness for us? Could you decrease it?
Two fingers. Use the two fingers with the distance, I
The
think.
side.
There you go.
Yeah, this
Very
is the
good.
minimum. Yeah, like.
Thank you very much. Thank you. Yeah, so it's very important because think of this monitor screen as your back, okay? as your back. So if you touch someone on the back, they can't tell if you're touching them with one finger or two fingers if they're very close to each other. You know? So you want to spread them apart a little bit to be able to tell the monitor whether you're using two fingers. So if I do one, it thinks it's just one finger. Okay? All right. Can we plug it in? I think it's the battery.
What's disconnected? Disconnected, right?
IT transfers, right? What if you plugged it into the wrong monitor? What will happen? Like for example, this monitor was not being used on this patient before. So the data in there didn't discharge the patient from the monitor. So the data in there was from a previous patient. What if I take this from another patient and put it in another patient's monitor? Yeah, so it will work. Yes, but it will give you a warning and it will tell you that the patient doesn't match, okay? So the patient in here and the patient on the monitor, if they're different, the names or the patient ID, if any of that is different, it will alert you. And yeah, so if you press OK, you know what is happening, then it's fine. So it will continue, but if otherwise you can cancel it. Yeah, so maybe you should.
But how about if they did not input the patient data?
That's what I'm saying, right? So then it wouldn't know
Because
that.
usually they are not they are not admitting the patient. Just use and monitor, that's it.
Called patient ID.
Scan na lang.
So I can click over here on the patient ID, and if I have the barcode scanner, I will scan and it will automatically input the patient ID. The barcode scanner works kind of like a keyboard. It's just that you don't have to manually type it. So you have to open the field where you want to enter the information. Okay, now here's one really important one, which I find I've been to a lot of hospitals because you guys don't usually operate the monitor that much. What happens is you don't change the patient type, right? Do you guys change the patient type? Anybody? Do you know how to change the patient type? Don't know. Okay. This is really important. Why? Well, first is because the algorithms that we are, like for SpO2 or ECG, the algorithms are more suitable to the patient's age. You know that the arrhythmia, in, let's say, a simple arrhythmia like tachycardia. Tachycardia in an adult patient should be heart rhythm above 120 or something, right? Above that would be tachycardia. But in a neonate, the normal heart rate is 150. So how would that be normal? So your alarm, your monitor keeps giving you alarms. And you're like, why is this monitor giving me so many alarms, right? Now there are two ways. You can go in there and you can tweak the settings. You can change the alarm limits by yourself. But also the arrhythmias look different in different patients. So let's say the ECG of a neonate is not the same as the adult. It looks different. So if you're using the adult setting on your patient, on a neonate, it might not give you that arrhythmia alarm that is so crucial to this life-saving, right? So it's very important to use the monitor correctly, not just blindly rely on its algorithms. This algorithm, when you're using it on an adult, for an adult, so here you can see it's saying adult right here. So I can click over here on sorry. So here you can see there are three settings: adult, pediatric, and neonate. Okay, so depending on your patient, it's best to choose the correct one. So if I give you a small example, I choose adult here. Let's see the arrhythmia settings, okay? So let's go over here and let's click monitor. I think the battery is over. So see, it's giving me a warning. It's saying continue monitoring the patient, or so which one do you want to monitor? The patient in the monitor or the patient in the module? So because it detected that I just entered some information, so it mismatched. So let's say I want to monitor the patient in the module, so I will click this one. It's giving me a warning and I click OK and then it's fine. Okay? So this is the advantage of using that information. Okay, now let's go over here to adult, and you can see it's here, it shows adult. This is really small, you can't see it. If you want to come over here, you can. It's showing you that the upper limit for this alarm is 120 and 50, okay? So this is for the heart rate in the ECG. Now when I change this to another patient type, let's say neonate, okay, now it's showing 200, the heart rate by 100, okay? So if it's within that range, it will not sound any alarms. And the algorithms are all now adjusted for neonates. So it's very useful to change this. You will save yourself some annoyance of unnecessary alarms, and also it will help you to accurately monitor your patient, okay? All right, now I have a question. This is the transport monitor that I took out. Where should I plug it in the monitor? Which, there are 6 slots, right?
Anywhere. Anywhere.
Anywhere?
Yeah.
What do you guys think? Yeah, if I want to connect the transport monitor to the larger monitor, where should I enter it?
You can click it up and also in down.
Here? How about here?
Can be also.
How about here?
Can be
It's
also.
all fine? Yes, it's all fine. Okay.
Can be also.
Yes, I know some other brands don't let you do it, but ours does, okay? Just take it and plug it anywhere you want, okay?
Same with mine. Anywhere you can put.
What?
Same with our mine. Anywhere. Modular kasi yan. Can put so many modules. CO2.
What is this?
Gas monitor.
Who knows what is this module?
CO2 module.
Capnographic, yes. So this is a side stream capnographic module, okay? So you connect a disposable tube over here, and then you can get the readings. I'm going to plug this back. Okay.
Actually, capnograph is very used in the OR.
All right. So any questions you have before I go on to my PowerPoint? What do you think?
This portable one can be used in MRI rooms.
MRI rooms? No.
No, it's not. About it's not right.
About ECG.
Yes.
ECG.
Yes.
I mean, I tried a lot of time, but it's not coming. It's very hard.
This is a good one, actually. Thank you for asking. I can tell you why. Actually, we have 4 different modes of ECG. Which mode are you using?
There is, on the picture, there is on 5 ECG leads should be connected. The other I do not know, only I saw the picture diagram where I have to connect these 5 leads.
Okay.
I tried but failed.
Okay. So let's see. Here is the ECG settings tab, okay? So, yeah, you can come, yes, sure. So you see over here, we say lead type. So it's showing you 5 leads right now. If you have the 5 lead and the selected lead type is 5 lead, it will connect. But if it's not, then you have to change it to auto. Just choose auto.
Auto.
Yes, you choose auto, then you can plug in any lead you want, and it will work. So you don't have to manually go in there and select that. So this is one thing. Another thing is, you see the filter mode being used here? The filter mode here is diagnose. When you use diagnose filter mode, it's showing you every single detail in the ECG. It's okay to see every single detail, but when you're monitoring a patient, you don't want to see the noise. Do you like ECG noise? Nobody wants to see that. So why you keep using it in diagnose? That wouldn't be right? So what you can do is you can go over here, there are 4 modes. You can go into monitor mode. Okay? So what monitor mode will do, it will automatically adjust the filters so that you have minimum interference. Okay? So you wouldn't see too much noise in the line. Another thing is, there is also an operation mode. So if you're doing surgery, or let's say endotracheal tube, whatever tubes you're doing, if you're doing some sort of operation where you're doing anesthesia, you can use operation mode. In operation mode, there's another advantage. You're using maybe cautery. So cautery, you use cautery, the electric knife, also called. So when you use it, it will filter that out as well. Okay. And then we have the ST mode. That's for patients with myocardial infarction. You can go and use it in ST mode. All right? Thank you. So use it in monitor and then use the auto lead type. So the advantage of using auto lead type is you don't have to worry about what lead you're using. Maybe one patient came in with 3 leads, the other came in with 12 leads. You can't go in and change every time, right? So having it manually letting you select it is, the purpose is so that, let's say everyone in this department is just using one type of lead, then it's fine, I can just choose 5 leads. But if you have 5 leads, 12 leads, 6 leads, 3 leads, or maybe a neonate comes with a 3 lead, so you can't just, because you're using this with a transport monitor, a patient can come in with any lead. So it's better to choose auto. So you don't have to worry about changing the lead type and why it's not detecting it, right, and this kind of work. Okay. Good. Anything else?
Sir, how about this pediatric probe?
Sorry?
Because we have pediatric probe.
Pediatric probe,
Yes, because only we have adult. And it will
For
not be detached.
SpO2?
Yes, yes.
We have pediatric probe. Here, this one is an adult one. We have pediatric probes. Where's the engineer?
But some monitors for EMS, the BioLite monitor, they did not give us the pediatric sensor.
Okay.
SpO2.
They should.
Yeah, so
Because it comes with the domestic adults, pediatric, and with each device.
But you cannot remove that one, sir. Not like the Mindray, you can
No, you
remove
can
and then
remove.
put it. No. That's what I'm asking always to the biomed. And it's not compatible. The one they're giving us.
So-
They know each one has its own wire.
so you're saying that you need a, because how would you use an adult sensor on a pediatric patient? That doesn't make sense. Actually, we also ran into the same problem in another hospital. They didn't use the adult, they were using adult cuff on pediatric patients. Like that's too large for an IBP. So yeah, we have all the sizes. We have neonatal, pediatric, and adult sizes. So you can just
Can
contact
I see which one she's using?
The SpO2 sensor.
SpO2 or
SpO2. Yeah, because
pediatric.
it's only one line. You cannot remove and put this pediatric probe and or
So
the
they just give you
neonate.
one for.
Yes.
So you're saying that the line is not split,
No.
or you don't have the probe, or both?
Only adult we have in EMS.
One second.
But they only give you one of this?
Yes, actually we have only one. That's for the adult, and it's only connected here. It's whole adult. We don't have the detached one
Oh,
like the
okay, so-
Mindray.
It's like using a Android charger with your iPhone. That wouldn't work.
Is it compatible or not?
No,
No, it's
it should
not.
be actually our employer is ordering all this type of.
No, actually the algorithm is different. So that
Even
even
you-
if the cable connected, it wouldn't work properly.
Even the same company, your BioLite, but different model like P series and Q series, it will not same probe.
Correct.
The problem.
Yes. It's because
There is a dedicated probe for that type.
absolutely yes. This is correct because if we don't update it, then the technology will stay in that age of the old monitors. We have to update our things. So the old iPhone, for example, used what the very large, the iPhone 4, iPhone 3, right? They had a very large connector, but later they used their Lightning port. Now they're using USB-C, right?
Yeah.
So we also have to update. So this is absolutely not ours, so
Yeah.
it wouldn't work.
But
So-
but you are giving the unit probe with not disposable, just reusable.
We have disposable ones, so if you want them, you just contact the
Okay.
Yes.
So we can order from.
Yes. So if you want to use
No,
something,
we order from them. They are giving this one. This is the one we are giving.
yeah, this wouldn't work.
Yeah. It also from the.
We never supplied this.
Well, where can we get this one? We come with a box. We have 5 box. We have.
These disposable?
This is possible use 2016 produced. This is not a pilot or not you.
No.
You didn't produce.
Because we are not ordering one piece only. We are ordering box. For example,
Yeah.
in the pediatric or in the Escabo,
Really?
we order box for 200 pieces,
But
500 pieces.
We only supply Mahindra and
Alright.
only. We don't have that.
I don't know, but when we check in our Escabo, they are using this one. I just take from the Escabo this one.
Feedback helps us to improve our line of communication. Okay, so we have disposable ones, we have reusable ones, so we can communicate and discuss that further. Okay, any other problems with the use of the device?
Yes, sir. Male surgical, because you have too much problem with this one.
BP.
But I mean, BB is not reading.
is not coming to the.
BB is not reading, so
Always
the screen monitor were lost automatically during connected to the patient.
What is that?
In the monitor there is a BP reading, but it is not coming to the central monitor.
Oh, it's not displaying on the monitor.
No, they are displaying in the monitor, but you should click the bedside. The bedside, it will show you the monitor. If you want
I
it
understand.
in the spot of the screen.
Because you're using a small screen.
Yeah, it's the using small screen.
Because for the, as you can see, there's the size of the words. Even if you get a bigger monitor, it won't change. It will increase the space on the monitor, but these numbers that you see are always the same size. It's because this is a regulation. So by regulation, we cannot change the size of the numbers. So if you use a small screen with the CMS, the numbers you see on the screen will be less. But if you use a larger screen, the bigger you use, the more numbers you see. So you have to click on there to be able to see the NMVP or blood pressure. Is because the screen size or the resolution of your screen is too low. So if you buy a bigger screen, this problem will be solved. Because we cannot change the size of the numbers. It's a regulation. We are a registered manufacturer, so we have to follow the rules. So that's why we get a bigger screen. Okay, I understand maybe sometimes even they don't know this, so they think it's not displaying that information, but it is. It's just
In our other department, like NLTC, it's appearing that one in the because I use this 150 inches monitor.
So,
Here is only 30 inches.
so maybe you are using a higher resolution monitor.
No, it's only TV that one. TV monitor.
No, it's not TV. It's the resolution of the screen. So if you're using a 4K screen, even if it's
The
smaller,
standard of this one. There's a standard for the central monitor. 19. Just check that one. There is a standard.
You'll need to unlock
You are
your. I
using
can only send.
because if you are using below or see 1024 by the maximum.
okay.
It
So
Screenshot.
in their department, go and increase the resolution and see if it resolves the issue. It should. It will
Small
resolve.
monitor that one there.
It's a small monitor.
Yeah, 32 inches only the TV.
That's the problem. So increase the size and it will be solved.
Change the.
All right. So I think we have resolved some issues here. Good. Okay, now let's take a look at some of the high-end parameters. So if you have used this parameter, do let me know, okay? If you know what this is. So let's go over here. Here we can see that the high-end parameters of our device are neuromuscular transmission monitoring. Does anybody know what this is? Nobody knows, okay. Regional oxygen saturation. Anybody know what that is?
Regional oxygen.
Yes?
SpO2?
No, it's not SQ. But good guess. Good guess. Yeah. It's similar to SpO2 but different. Okay. Next, EEG.
ECG.
Yeah, electroencephalography. You guys know what this is, right?
Yes, we use our option for that one.
Yes, yes.
For the
All of these are available.
In the P series.
Yes. These are available.
How about the electrodes we want to use? The electrodes that we are using for the EEG.
Yeah.
There is available also.
It's actually a cable. There is no electrode. You just put the gel. Yes. So it's a cap. I will show you. There is no electrode.
Oh, I think.
There's no disposable electrodes, is what I'm saying. And then we have anesthetic gas, maybe for surgery guys. Anyone here from surgery?
The OR.
Anesthesia? Okay, so that's your gas. But this can also be used in ICU because you have anesthesia in ICU, and also because it has oxygen monitoring. So you can monitor your end-tidal oxygen or your fraction of inspiratory oxygen. Then we have CO2 capnography. BIS, bispectral index. Anybody knows?
BIS, yes, for OR.
So this one is for OR or ICU. Okay. And then you have respiratory mechanics.
RA module.
No idea.
For RT.
Impedance cardiography.
ICG.
Okay. Invasive blood pressure, you know, right?
Yeah.
And cardiac output. Okay, let's go over them. Okay.
Cardiac output. We are using
Alright.
TAPLAP or CC.
Okay, this is neuromuscular transmission monitoring. Okay. So this is a NMT device. It's used in anesthesia patients that are under hypnosis. Okay. And you know, in anesthesia we have three kinds of drugs. We are trying to make the patient unconscious, right? And we are trying to make them pain-free, analgesics, and we are trying to make them we're preventing them from moving. We don't want them to move. So we're using neuromuscular transmission monitoring to see if the neuromuscular blockade, the drugs that we gave them, they're working or not. And are we overdosing them or underdosing them, okay? So it's an objective monitoring technique for your neuromuscular blockade. What is interesting about this is it has different modes. So I think for most people, they might know this as TOF, train of 4, because it sends 4 electrical signals. I will show you. Okay. Is the audio okay? Interesting. Yeah, so you can see there is a nerve, and it connects to the muscle through nerve fibers. So we can use this in different areas. So you see it sends the electrical signals. You can see over here. 1, 2, 3, 4. You see how the thumb moves? Yes. So it's showing you whether there is enough neuromuscular blockade or not. So the graph kind of looks like so I can use different modes. The graph kind of looks like this. So this is called fading. That means the first time the thumb moved, it was like 100%. The second time was like, I don't know, 70%, 20% or something, right? And the fourth time it didn't move, so you don't see a bar over here. So this is called adequate neuromuscular blockade. So you can see that it only moved 3 out of 4 times. That means the drug you have given to the patient is adequate, is enough. If you give too much, then the TOF will decrease from 3, it will go to 2, to 1, to maybe 0. So that's too much. You're overdosing your patient. And if you give too less, then the TOF ratio will be higher than this. So it will move all 4 times, and the TOF ratio will be around 1. Okay? So if it's around 1, that's too much. So these are all the different modes. This is the train of 4. This is double burst mode, so it only sends 2 electrical signals. And then there's a PTC and all these other modes. We have a special mode called auto mode, which automatically chooses the correct mode for your patient during surgery. So before surgery, when you're beginning, it will be in PTC mode. Then when you start giving neuromuscular blockade, it will change to double burst mode. And then when adequate neuromuscular blockade has been achieved, it will automatically change to trainer 4. Okay? So it's like automatic procedure. You don't have to switch modes for everything. So the purpose of switching, like using the auto mode is, that means you can get the most accurate monitoring method during that period of the surgery. Okay, so it's a device that ensures the patient won't move during surgery or when intubated in the ICU. Okay, so this is the main use of this. It also helps prevent injuries during surgery. You don't want your patient to move, and it also helps reduce side effects. Okay, because you're not overdosing your patient. Okay, this one is also interesting. It's bispectral index. I'm just going to skip over the video. Okay, bispectral index. So you see over here you have a very long waveform over here. This is the EEG waveform, okay? And here you have a number. This number is bispectral index. And it's very interesting, this number, because even if you're not an anesthesiologist, maybe you go to the ICU or you go to a department where they're using this and you see that number and you know what it means, right? So right now, do you know what 37 means? Body temperature? No. That's a very interesting way to put it. 37 is the body temperature. But this is bispectral index. So you're using the electrodes on your forehead. Do you know what 37 means if the base is 37? Anybody? Okay. So let me tell you. If the base is 100, that means the patient is awake, fully awake, alert, conscious. 100 or close to 100, okay? And if the patient's base is around 30, or let's say 40 to 60 is a normal range, the patient is under anesthesia, adequate anesthesia. Below 40, you would say too much anesthesia, so decrease the dosage. So this is a little bit too much, okay? But it's around the normal range. So this is what it looks like, you see? So it's very easy to, you know the depth of anesthesia. But if you just read EEG, the only thing you would know if the patient is awake or not, right? And I think most of us can also do that by just looking at the patient. The bispectral index shows us the depth of anesthesia, how deep of anesthesia has been achieved. You know what's the purpose of that? The purpose is you don't want your patient to wake up during surgery, right? If a patient wakes up, that's game over. And then you also want to make sure that they wake up quickly after surgery by not giving them an overdose. You don't want to give them overstay in the post-anesthesia care unit.
Also in T was anesthesia?
Yes, it's also for anesthesia. So this helps prevent memory of surgery, and it also helps reduce side effects. Okay. Now this one is interesting because this is almost can be used in every department. This is called RSO2, regional oxygen saturation. So no matter which department you are, you can use this. Now it's similar to SpO2, but SpO2 is used on your as a fingertip pulse oximeter, right? And it's detecting the oxygen in your blood vessels. So it's checking how much oxygen is there bound to your hemoglobin. If all of the hemoglobin in your blood is bound to oxygen, the value on your SpO2 will be 100, right? Now, this, on the other hand, is different. This is regional oxygen saturation, so it's showing you the oxygen levels in the tissue, not the blood vessel, okay? So, if I put it, let's say, on my arm, on my leg, it's showing me how much how much oxygen is there in the tissue, in the muscle, okay? So, you know, if I put it on my forehead, what's it detecting? If I put it on my forehead, cerebral oxygen, the oxygen of your brain, right? And that's why it's also called cerebral oxygen monitoring. Because even though you can use it on anywhere, any part of your body, But the most important organ we care about is your brain, the oxygenation of the brain. So you can use it like that. So this is what it looks like. You can see we can select the area on the monitor. So this is just a label. So it shows you're using the RSO2 on the left forehead or on the right forehead. This is the baseline. So this is always less than SpO2. The value of the oxygen in your tissue is always less than SpO2. You know why? Why is oxygen level in the tissue lower than the oxygen level in your blood? Who knows?
Because there is cell in the blood, they are carrying the oxygen.
Very good. Correct.
And,
Yes.
in the tissue, of course, it should be penetrated.
Very good. Yes, she's right. Because it's away from the blood vessels. So in the blood you have, let's say, 100% oxygen. SpO2 is 100. But as you move further away from the source, your oxygen levels should be lower. And another reason is the tissue is using the oxygen. They're consuming it. So once they use it, the RSO2 value should be lower. So, but just by looking at this, what side of the brain this person is using more? The right side. So that means the left part of their body is dominant. They may be left-handed, right? Because we know the brain crosses over to the other side. So this person might be left-handed, okay? It doesn't have to be like that, because I feel like it's always different in different people. But it's an interesting theory that they might be using that side of the brain more, okay? So whenever you have an SpO2 value and RSO2 value, you can compare them. So if, let's say, your SpO2 is 100, but your RSO2 is 65, that means the blood has enough oxygen and your tissue is using that oxygen, okay? But if the values are too close, let's say, you see there is a delta SpO2? Delta SpO2, this value here. Let's say that when you were monitoring the patient, you realize SpO2 is 65 and RSO2 is also 65. That means the oxygen saturation decreased in the blood first. So there's something wrong with the oxygenation of the blood. There's nothing wrong with the brain. Maybe it's not aneurysm or something like that. But what if the SpO2 is 100, just like SpO2 is 100? Why is there so much oxygen in the tissue? It shouldn't be. That means your tissue is not using the oxygen. If your tissue is not using the oxygen, that means the tissue is dead. Okay? Another reason why the tissue, the regional oxygen saturation might be 100 is because bleeding. So if there is a traumatic brain injury, you suspect that this patient bumped their head somewhere, and you put on an RSO2 on their forehead, and suddenly you see 100% reading, or very close to SpO2, like the delta SpO2 is less than 10, then you should be worried about something, and maybe do a CT scan or something, okay? Another thing RSO2 can help you with is observe your CPR efforts. So when you're doing CPR, how do you know if the patient's brain is receiving enough oxygen? So you place the RSO2 on the forehead, then you do the CPR, and you should see an increase in oxygen levels. Okay? So this is the use of RSO2. This is what it looks like. You see, it goes over the forehead. So it's a device that ensures oxygenation of the tissues, especially the brain during surgery, during CPR or in the ICU. And yes, you can use it in any department, wherever you care about the brain. The only thing that prevents you from using this is if a person doesn't have a brain. So if the person doesn't have a brain, you can't use this, sorry. Helps prevent tissue damage. Helps visualize resuscitative efforts. Okay. So I've introduced you 3 parameters. One is BIS, one is NMT, and one is RSO2. Which of these three do you find a little bit applicable, if not completely applicable, to your department? Okay, so if you think you will ever use RSO2 or you might be interested in using it, can you tell me? Can you raise your hand? RSO2. Okay. What about BIS? No?
This we are using in OR.
Yes.
Yeah, BIS in OR. Yeah, yes.
And how about NMT? Okay, so for you guys, RSO2 was interesting. Okay. Next is respiratory mechanics. This is basically like you can see the pressure, volume, and flow of the air that the patient is connected to a respirator, a ventilator. So the parameters you see are very similar to what you would see on a ventilator. Okay, but there's a difference. There's always a difference. Do you know what is the difference? So the parameters you see on a ventilator, they are further away from the patient. So that means you have a lot of dead space in the middle. So you're not accurately monitoring those parameters. So what you are actually observing is what the ventilator is outputting, like what you have set, rather than what the patient is receiving. So, if you want to observe from the perspective of the patient, what are the lungs of the patient experiencing, then you need a respiratory mechanics module, because this connects to the Y tube directly over the intubation pipe. So it connects next to the patient. So you're further away from the ventilator, where you're closer to the patient. That means you have less dead space to worry about. So you can have a very long pipe to the ventilator, but your readings will not be affected. This is to ensure a safe ventilator administration. And another thing it can be used for is diagnosis. So you can use, because it has respiratory loops, like flow and volume loops, and pressure volume loops, and pressure flow loops, okay? So it will draw a loop over here that you can use to diagnose different diseases, like COPD and whatever. Okay, so it's a device that ensures proper ventilation of the patients and prevent lung injury during surgery or in the ICU, and helps prevent lung damage and helps diagnose patients' lung conditions. This is your EEG that you were asking about. You can see that there's no electrodes here. These are cables. I mean, technically, yes, they are electrodes, but it's not the same disposable electrode, not that kind of thing. So this thing just connects to the cap over here. You just press it in, and then you insert a gel, and you're good to go. So it kind of works like this. So we have a EEG, we have DSA. You guys know what DSA is? Okay, it's an easier form of EEG, okay? It's easier to read. This is a multispectral analysis, multi-taper spectrogram, and you can see that this is very easy to read. Do you know how to read it? Anybody knows how to read the EEG? Do you want me to tell you? It's very easy. I can teach you like in 2 minutes. Okay. Okay, first you need to know the waveforms, okay? So maybe you need to know the 4 frequencies. There are 5, but you need to know 4, okay? You know alpha wave? Alpha waves? Yes? Beta waves? Okay, there we go.
D waves.
Yeah? Delta waves?
D waves.
Yes? Gamma waves? What else? Yes? Alpha, beta, gamma, and then? No, we don't have omega waves. I wish we did. Okay, anyways. So, which wave is from the frequency of, let's say, 7 hertz all the way to 12 hertz? What frequency? So this frequency, 12 hertz to 7 hertz to 12 hertz. What wave is this? Okay, it's the alpha wave. Okay. So alpha wave means that the person is awake. They're not sleeping. They're awake. They're conscious with the eyes closed, like this. So if your eyes are closed, the only waves that would be coming out of it, the power of that wave will be the strongest, okay? So you see, in the first 5 minutes, we see a lot of alpha waves, and here we see the spectral edge frequency, which is closer to 25. So if the spectral edge frequency is this high, And then we have an alpha wave for the first 5 minutes. That means the patient is awake with their eyes closed. Okay? The spectral edge frequency is closer to 25. So between 15 to 25, it's the beta wave frequency. If it's within that range, then the patient is awake and their eyes are closed because we don't see any waveforms over here. But then you can see that this, the most powerful ones, the waves, they are all in this region, most strongly in the delta region. So this is because the patient is, and you can see the spectral edge frequency has decreased. This is because the patient is either under anesthesia or sleeping. Okay? It's easy, right?
So delta is sleep
Delta is your subconscious. Yes.
and beta,
Beta is when you're awake with your eyes open.
alpha with your eyes.
Eyes closed. There you go.
So during the EEG procedure, like they are doing putting, they are blinking light for the eyes of the patient. So what type of waves they are using for that?
They're not using waves. We're detecting waves, monitoring.
Monitoring waves, what type? How?
We are monitoring all of them, all 4 of them, and we will see what the patient is experiencing.
Because in the EEG there are procedure for doing putting. You know, they do with the light, the strong light blinking to the
Yeah. That procedure is to detect seizures in a patient.
Okay.
And for that, most of the time you would use a full EEG. This EEG only has 4 electrodes.
Okay.
This is for monitoring.
Monitoring.
This is for monitoring a patient. So if you already know where, let's say there's a tumor, and you have maybe a tonic-clonic seizure patient or something, you can put the electrodes where you are worried about the most, over that area, and just monitor that area. You don't have to, because you're not diagnosing the patient, you're monitoring the patient. This is a patient monitor. So this is one purpose. Another purpose for EEG on a patient monitor is to detect brain waves in a patient you suspect of brain death. So you can use this to monitor if there's any brain activity in this patient.
Good parameters in ICU.
Yeah, so this is your DSA. We also have, of course, the CSA, which is a normal waveform of the EEG. Okay, so it's a device that shows the brain activity, helps diagnose neurological disorders. So, of course, it will not be a very detailed diagnosis, but if you are monitoring someone on EEG that perhaps have some issues you know already, or you're worried about, and then you can see what time of the day they have the issue or what triggers that, right? So yeah, it can also be used to kind of like bispectral index during surgery. However, the bispectral index shows you the depth of anesthesia. This does not show you the depth, only shows you the current brain activity. And yes, it can help you declare brain death. Okay, so who knows this one?
I see.
Yes, this is very easy to use. It's a non-invasive cardiac output monitoring device. So if you're trying to monitor someone's cardiac output, let's say in the CCU or in the surgery or in the ICU or in the ER or wherever you have cardiac patients with decreased cardiac output and you want to monitor them, you can use ICG, and this will non-invasively detect your cardiac output. Okay. So for example, you can put 8 electrodes, 2 on each side of the neck, 2 on each side of the thoracic cavity, and it should give you the waveforms and the parameters for the cardiac output. This is the invasive cardiac output. As you know, this is Swan-Ganz catheter. You guys know this one? Anybody who has done cardiac output? Never
For the
used it?
cath lab at the CCU.
Okay. Well, anyways, this is the invasive one. It's a normal thing. It's not a new thing. So I'm not going to explain this. Yeah, here's the advantages and disadvantages. Okay. Now, I know all of you use SpO2. Now, Have you guys seen this kind of SpO2?
Fast saturation.
Okay, this is Massimo SpO2 with rainbow parameters. Now, what does that mean? Well, actually, they have 7 parameters, as you can see from SpO2. Normally, we have like what, 2 parameters? 3. We have SpO2, we have perfusion index, and we have pulse rate. 3 parameters from SpO2, right? But here you have 7. So here you have, this one is the SpO2 value, of course. Then we have these parameters you can see here. This is a common one, perfusion index. We know what it is. Everyone knows what that is, right? Perfusion index shows you if there is enough perfusion to the tissue. So for example, you're using SpO2, but suddenly the perfusion decreases below 1, maybe even below 0.3. Okay, that means there is not enough perfusion to the finger. The value should not be accurate. Maybe you pressed it too hard, or the patient is using something under a pillow under their arm. You know, when you use a pillow under the arm, it occludes your brachial artery. So the supply of oxygen or supply of blood to your finger will decrease, so that the perfusion value will decrease because of that. So the perfusion value is kind of like a signal to tell you whether the patient has enough perfusion in this area to be monitored for SpO2. If it's above 1, that's normal. If it's less than 1, you should change the finger or change the hand to another one. If it's below 0.3, the perfusion is too low. Okay? You can also observe low perfusion when the hands are very cold. So if the patient has really, maybe they're using the air conditioner and their hands were really cold, you will see low perfusion because of that. So the monitor cannot detect the oxygen levels if there is no blood properly supplying to those areas. So it's better to warm up their hands. And if your hands are too dry, that is also an issue.
Henna also. Even
Yes, yes, absolutely. Any tattoos or any kind of discoloration, even if, like, let's say they bump their hand into something like this, and it discolors, that will also affect the SpO2 reading. So don't use that finger. First, if they bump their hand into something, that finger might hurt. So maybe it's not a good idea to use that finger in the first place. Another thing is, because of the way SpO2 works, is it's an infrared sensor and a red light sensor. So when the color of the skin changes too much from the normal skin color, the values will be affected. So it's best to use a normal skin color. It doesn't really matter what color your skin is, as long as it's normal, it should work. Because infrared cannot see color, actually. Yes, but when there is a change in color, what happens is, because there is extra pigmentation, it's not normal anymore. Maybe there is too much, let's say, white blood cells in there or whatever, it's inflamed. So when there is discoloration, it will affect your SpO2 values. So use it over normal skin. But yes, that PI, perfusion index, should help you with that. Then we have PVI. This is pleth variability index. It shows you if the patient needs fluid resuscitation or not. So it's kind of like pulse pressure variation or PPV, you know these parameters? So let's say the value of a PVI is more than 14. Okay, that means the patient can be resuscitated, like you can give them fluids. If the value is lower than 14, you have to be careful when giving them fluids. Maybe you might overdose them. You might give them too much fluids, overload their heart. And if the value is below 10%, you should not administer fluids to this patient. If you do that, you will increase the cardiac load too much. Okay? So that's the purpose of PVI. Now look at this one. This one is, okay, actually let me show you the names of the parameters. This one is carbon monoxide, okay, SpCO. So you know normally you do arterial blood gas, right? You do an IVD test to detect if the patient has carbon monoxide poisoning for whatever reason. Maybe they were in a burning building or whatever. Or maybe they were on a ventilator too long where you forgot to change the soda line. right? So if they have carbon monoxide poisoning, you can non-invasively and almost immediately detect that with SpO2. It's not an alternative to APG, but it is definitely an improvement to that. Because it will save you at least an hour, right? So you can detect poisoning early. Also, I will talk about SP-MET in the same time because this is related to that. If you have methemoglobinemia, maybe your hemoglobin is altered because of some drug interaction. Maybe you use too much lidocaine on a patient, or you injected lidocaine intravenously. So yeah, you will have methemoglobinemia. And it can also happen due to some other reasons that we still don't know. So if you have that, you can detect that. Then we have the total oxygen content. So this is similar to what we see on SaO2, the arterial oxygen saturation. Yes, or SvO2, venous. So this one is showing the total oxygen content, okay? So the thing to remember here, this is non-invasive. It's not invasive at all. And here, this one is interesting because ignore the value, 25 is too high, but this is hemoglobin levels. So you know, there is no other technology that can non-invasively monitor hemoglobin levels. So this is the only way you can do that, and continuously. So we'll show you the hemoglobin levels, the charts, that kind of thing. Okay, I'm going to show you two clinical assistive applications. Okay, so in this monitor, there are some applications. I know usually you don't think of having applications in a monitor, but there are two applications. One is for sepsis. So if you know the sepsis guidelines, you will see that they're kind of quite hard to follow. So we put the sepsis guidelines into the monitor. So you can go over there and step by step follow them, and there's a checklist. So if you've done some procedure, you can check it and it creates a log for you to follow. And you have sepsis scores and other things over here. And this is, for anesthesia, this is the balance of anesthesia view, and it basically guides you throughout the anesthesia process. Since no anesthesiologists are here, I'm going to skip this. And here is early warning score. Do you guys use early warning score here? Any kind of early warning score? Yes? Yeah, okay. Which one? Muse, okay. Yeah, so we have Muse over here. The one you're currently seeing on the screen is Muse from National Early Warning Score from the UK. It's the second version, the latest one so far. But we do have Muse as well. So you can go over here in the settings, and you can, so this is here, the setup, and you can change it to Muse. Sorry. And you should be able to read what you need to do to the patient, how to inform, or you can enter the values. So some of them are automatic, for example, respiratory rate. If the patient is connected to the monitor, some of them will be automatically detected. But the ones, for example, the consciousness level or something, you have to manually input that. And then it will give you a score that will be displayed on the monitor. And then you can set an expiry time. After some time, you can go in and change it again. So it helps you calculate, and it also keeps like tabular trends and graphical trends to show you some information. And GCS, do you guys use GCS score? Yeah. So you can use GCS over here based on the patient's response. You can click, and it will show you the value directly on the monitor. Okay, so that's all for the presentation. Now, before you guys go, give me this paper out this time. This is just the last page I printed. So, but the questions I asked you cover them.
Attendance. Yes, sir. Attendance. Attendance.
So the response parameters like SpO2 can be detected. The monitor can monitor